Marvin Goldfried is a distinguished professor of psychology at Stony Brook University, where he helped to develop the graduate program in clinical psychology. He's the co-founder of the Society for the Exploration of Psychotherapy Integration. Alan Francis is a professor of psychiatry and chair emeritus at Duke, and was chair of the DSM-IV task force. Marvin describes the evolution of his psychotherapy orientation as psychodynamic, behavioral, CBT, and eventually integrative. He practices, teaches, and supervises what works clinically using direct and indirect evidence base. Alan describes his approach to psychotherapy as whatever works, or no one size fits all. He was trained and taught at the Columbia University Psychoanalytic Center, but remains equally interested in brief, supportive, cognitive, behavioral, interpersonal, and family therapies. Please enjoy this week's episode.
Good morning and welcome to Talking Therapy. I'm here with my colleague, Alan Francis. Good morning, Alan.
Hey, Marv.
And I'm Marvin Goldfried, whichever you prefer. And we decided on an interesting issue and came up with an interesting label for it. Supervision, teaching old tricks to new dogs.
Did you make that up, Marvin?
What's that?
Did you make that up?
I made that up, yeah.
That's brilliant.
Well, let's unpack it and see whether it's more than just a kind of a cute title, and what's in there. And let's talk about what the tricks are. The old tricks. Are they good old tricks? Are they bad old tricks? And then we can segue into the nature of the supervisory relationship and how that is used to convey information about therapy and also the particular patient. Okay, I have ambivalent feelings about old tricks. Some old tricks are good, some old tricks are bad. And when I think of teaching old tricks to new dogs, I think of the saying, you can't teach new tricks to old dogs. And if the old dogs are doing the supervision, are they teaching antiquated therapeutic tricks? What they have learned over the years and have not changed, and then just passing on and perpetuating something. So what do you think of that?
Well, my bigger problem is with the word supervision, but we'll get to that later. I think that what's essential in psychotherapy hasn't changed a great deal, probably for the last 50,000 years, much less the last 50. And while there are certain nuances that have improved our ability to work with different types of patients more specifically, that by and large, what basically is healing in psychotherapy is probably not at all new, probably goes to the oldest and most essential parts of what makes us human. So I think if we can teach people the old tricks, that's just fine, because I think those old tricks are pretty special.
So some of these old tricks are, how can the supervisor do something to influence the supervisee so the supervisee can then go on and heal the patient?
Yeah, and I go further. I have a lot of trouble with the word supervision, because there's sort of a police function involved with that, monitoring. And I see the relationship as more wonderful and special and liberating. And the relationship between a really good supervisor, I hate the word, and a really good supervisee, even a more idiotic word, that relationship is a wondrous, magical relationship. It's not one of the supervisor monitoring and making sure that the supervisee says just the right thing at just the right moment. That's a perversion of supervision that I think is too often practiced. That it's more liberating, inspiring. The supervising relationship is really an inspiring relationship, an initiating relationship, in which you're helping to bring a younger person into our field. You're helping them to realize the strong points in their personalities that will help people, the healing parts. You're helping them to realize the parts of their personalities that may sometimes get in the way. You're giving them permission to do our work. So I see it as a very deep and meaningful relationship that goes well beyond just teaching tricks.
Yeah. Well, I mean, yes, and the teaching tricks is just a metaphor, maybe not a very good metaphor, particularly if you associate that with teaching techniques to the student, which they can learn by watching videos or reading books. But
getting a chat box.
Yeah, oh God, please let's not go there. But what you're talking about is to use maybe a better metaphor, is passing the torch.
Perfect.
Yep.
Perfect.
And
providing a rite of passage.
Uh-huh.
You don't go from being a civilian to being a therapist without there being a change in the way you see yourself, the change in the way you see the world, acquiring an attitude, a feeling of responsibility, a sense of unselfish caring. And that I think by identifying with treasured torchbearers, we become who we are. I think, to me, actually, I'm not sure whether this is personal to me. I was much more influenced in changing as a person through my experience with really important supervisors than I was in my own therapy. My own therapy helped some, but I think that the supervisors had even greater impact in who I became.
Well, you were fortunate to have good supervisors. I had very few good supervisors. I had to do a lot of bootstrapping.
You're a self-made man, Marvin.
Yeah. Well, teaching and getting feedback from students, demonstrating therapies, certainly was important in my development as a therapist.
Which is really, let's just make that point. It's a two-way street. Each of the people that we help to initiate passing the torch on is also enriching us, making us better.
Yes. Well, it's like what we spoke about in a previous podcast. We are at our best as a human being when we do good therapy.
And good teaching.
And good teaching and good supervising. So if we can demonstrate, if we're good therapists, if the supervisor, let's say, is a good therapist, and they are able to demonstrate that approach in doing helpful supervision, then one of the learning mechanisms is observational learning, modeling.
Yeah, there's a whole interesting literature on parallel process, how very often what's happening between the young therapist and his or her patient, and what happens between the young therapist and his or her supervisor has a parallel. And the same kinds of problems that emerge in the treatment also emerge in the supervision. And the way the supervisor handles them provides
and the parallel process, I think, is great. You know, it's essentially having the interaction between supervisor and supervisee parallel what goes on with therapist and patient. And that's where I start getting uncomfortable about teaching these tricks. Because what I have observed is that, let's suppose the supervisor is a person-centered therapist, and the supervisee, who knows very little, has a panic patient and wants to know, what should I do? And the supervisor then says, well, so I understand you want me to tell you what you should do in this session. And the supervisee says, yes, I really would like to know. Okay, so what do you think should be done? And if the supervisor is person-centered, and that's an old trick that they have learned when they became therapists, and it's a parallel process that the supervisor is using, is this good supervision nowadays, 21st century?
Well, you asked the question, Marvin. What do you think?
Well, I was being person-centered, so I wanted to find out what you think.
I don't fall for those tricks, Marvin.
No, I think it's terrible. You knew that. You just didn't want to, you just didn't want to say it. I know your tricks.
Why is it terrible?
Well, because there's a body of knowledge. Could you see somebody learning surgery, and there's the student there, and okay, you take over. What do you think you should do here? Well, what should I do? The person's bleeding. Well, what do you think should be done to stop the bleeding? Let me think. No, there's no time to think. You can't do that. But then again, as you correctly point out, there's a special relationship, and the supervisee needs to grow as a person. So what's the balance between telling them what to do and having them figure out what to do? And there would be some supervisors who will say, let's just tell them what to do because here's the technique. And there'll be others, like a CBT therapist, and somebody else who's person-centered, and some psychodynamic therapist, excuse me, would say, well, why don't you figure it out for yourself? And I think those two extremes are not good. These are old tricks, but they're not good old tricks.
Yeah, I think to expand on that, just as there's no one right way of doing therapy, it all, as we said last week, it all depends. It depends on the patient, it depends on the therapist, depends on the context, it depends on the stage of the person's life, the presenting problem, the supports, the stressors. It's very hard to come up with rules of the game, algorithms that say do this when this happens, because it's so complicated and there are so many permutations. Supervision is just as complicated. That it depends. It's never do this. It's always it depends. It depends on the supervisor. It depends on the therapist. It depends most of all on the patient, what the patient needs. It depends on the problem that the patient presented with, the context of that problem. It depends on the skill and the personality of the therapist. It depends on the match between the therapist and the patient, so that you could have very different results because they just hit it off or they don't hit it off.
Yeah, yeah.
There's good chemistry or not. That the role of the supervisor is to make it work somehow, to make it a useful therapy and to make it a useful supervision, to be a role model for the therapist so that they will get a sense of accomplishment and of identity and of direction from the experience. And most of all, that the patient's going to be helped rather than harmed or left unchanged from the therapy. So like everything else in life, it depends.
Yes, and given the fact that I don't know of really great definitive research that has truly addressed the questions of it depends, because there are so many different factors that it depends on, then here's the supervisee who doesn't know what these conditions are, and then relies on their therapist, their supervisor, in order to say, well, in my clinical experience and what I know of the literature, but also what I've seen clinically, with this kind of person, you don't do this. This kind of person, and there is some research on this, who needs to do it their own way, it's probably not a good idea to tell them what to do, but to work with them and have them figure out what to do. Makes sense clinically, and there's some research on that. So one of the functions of the supervisor is to deal with answers to it depends, or on what does it depend.
Yeah, the quote from the beginning of Tolstoy's Anna Karenina, that all happy families are happy in the same way, all unhappy families are unhappy in their own special ways. I think to some degree it's the opposite when it comes to supervision.
Could you say that again?
The beginning lines, the beginning paragraph of Anna Karenina by Tolstoy, all happy families are happy in the same way.
Yeah.
All unhappy families are unhappy in their own particular way.
Right. That's interesting. Yeah.
But I think in some ways it's the opposite with supervision, that all happy supervisions are different, that there's no one model for a happy, useful supervision. On the other hand, there is a model for bad supervision, for unhappy supervision, and that is where the supervisor has a hammer and is looking for nails, not only in the patients, but also in the supervisees, where there's a kind of inflexible, this is how we do it, and rote kind of manualized supervision, just as they're in parallel to manualized treatment, that doesn't recognize the individuality of the patient, the individuality of the therapist, and then the complicated, weirdly complicated individuality of their matchup.
Yeah. And the hammer is often a theoretical hammer.
Yeah, and one of the things that is also crucial in understanding supervision is that it's always behind by a week. I would always tell the people I was working with, hopefully there'll be something useful that comes out of our meeting today, but it's probably not going to be useful for your next session. Because if you're focused on what we're saying now, you'll not be focused on what the patient is saying then. You need to keep an open mind and not be coming into each session with a preconceived notion based on what we say today, because what we say today may no longer be where the patient is next week.
Well, I think a nice way to train that, because basically what you're saying is supervision should help the supervisee hear and see things that they might not otherwise see or hear. And watching videos together and then stopping in and commenting, notice, what do you think is going on now? And this kind of stuff too can occur not only in supervision, but you can have video training tapes that train therapists, beginning therapists, on how to observe and how to hear, how to pay attention, and with both eyes and ears. You know, interestingly enough, one of the most important books I ever read as a graduate student, which was Psychodynamic, was Wilhelm Reich's character analysis, because he spelled out the importance of seeing what goes on in therapy. And I think it was him who said, you can't say nothing was going on, because something is always going on, even if it's nothing. And then why is it nothing? And that was, you know, this was published in the 30s, clearly before any kind of videos that existed to train this listening and hearing. So I do think, you know, that is something that's an old trick, but it's a good old trick. So we have to, I think, make distinctions between old tricks that are good old tricks and your rule of thumb of following the patient, I think, is a good guideline.
And I think we have to recognize that there are potential harmful unintended consequences of supervision.
Yeah.
That supervision can make the therapist a worse therapist, make the treatment a more difficult and maybe unsuccessful treatment. I think that the two biggest problems are the one that you were alluding to a moment ago, that in helping the person see things about the patient that they haven't seen before, the danger is that the therapist will then see just that thing and not the rest of the patient. The supervisor hones in on a particular issue, and that becomes the subject of supervision.
Yeah.
The danger is that puts the rest of the patient out of focus, and the therapist is only seeing the thing that they discuss in supervision, missing the rest of the patient. I think the other big danger is that it makes therapists self-conscious. That if the therapist looks at the supervision as a kind of test, I'm going to go in each week and I'm going to tell what I've done with the patient, it's very important I get a good mark, and that the supervisor thinks I've done a good job. And if that makes them inhibited, it makes them shy about saying things. It's always easier for supervisors to criticize errors of commission than errors of omission. And this can freeze therapists. It can make them so worried about being criticized that they wind up being ineffective because they say very little.
Yeah. Let me just get back to your first point of sometimes the supervisor says, here's here's the thing you got to look for, and then that becomes the primary focus of the therapy, and it may be inaccurate. It may be a bad old trick. I'll give you an example. I had a supervisor who said, I had a patient who was this was back in the 50s, lower back pain. And he said to me, I think this person may be a latent homosexual. You're laughing, but that's, I tried to control myself, but he wanted me to explore this person's sexuality, and try to uncover any homosexual fantasies that this person had. That's an old trick. It's a very old trick. So I think we need to know old tricks that are good and old tricks that are bad. That's one important thing. And then, how to do it, and some of the other functions of the supervisor. One thing that I found very helpful when I was with one supervisor was it helped calm me down. I was presenting about a crisis in a person's life, and I was feeling very stressed about it. And there was a male supervisor, and he was saying, well, here's what you need to do, and putting it in context. And the way that he didn't panic the way I did. So I figured, well, maybe it's not that serious. So I was able to model a more clinical, less rather than personalized, stressed attitude toward looking at this. And this is, part of what I think you're referring to as the sometimes hard to describe characteristics of the interaction.
Well, Marvin, what should a trainee do if they think the supervisor is missing the point, focusing on the wrong thing, not really getting it?
It's a very, very tricky kind of thing, because and this is a controversy I know that has existed in certain places in Europe in the past. I don't know what the current one is. And that is, should faculty supervise clinically? And there's pros and cons. And if the faculty person has power over the academic status of the supervisee, then the probability is that the supervisee may withhold certain information, such as disagreeing, because they're afraid of potential repercussions.
Yeah, I think it's a very tough one. First of all, we shouldn't assume that the trainee is seeing it clearly. It may be the supervisor seeing more deeply than the trainee has the advantage of being in the room with the patient. The supervisor has the advantage of experience. But you can't tell just on the face of it in any given situation who really, when they disagree, who really is closer to what needs to be seen and said and done. But I think that a trainee who disagrees with a supervisor, the first thing to do is to try to bring that disagreement into the room and have a discussion about it. That discussion is likely to be enriching to both, correcting errors on both sides. And if it's left unsaid, the supervision becomes almost irrelevant to the treatment, and in some ways no longer supervision, because they're discussing something abstract, not what really is felt by the therapist and what's being experienced in the room. So the thing I would urge trainees to do when they think the supervisor is off base is to not keep it to themselves, not just go ahead and do what the supervisor says, not just rebel against the supervisor, do what you want. The best way of dealing with these situations, at least to give it a try, is to point out the difference of opinion and try to discuss how come the two of you are seeing it so differently.
Yeah, so the supervisory relationship has to lend itself well to that.
Yeah, just as we want truthfulness and we want patients to feel comfortable telling us when they think we're screwing up, because that's a very fertile discussion. And the discussion, if not had, means the treatment's kind of stalemated. If it's subterfuge, if it's underground disagreement with what's happening, the patient feels it's useless but not willing to talk about it, then that makes it impossible really to have a useful treatment. Similarly, when there's a disagreement between the trainee and the supervisor, having that submerged rather than openly discussed means that the supervision is compromised, and maybe the treatment will be compromised too.
Well, there's a lot of clinical research that's been done on ruptures in the therapy alliance. I don't know how much has been done on ruptures in the supervisory alliance, but I think that's a very interesting point. And I think, that is certainly worthy of some kind of research, even if it's survey research or qualitative research. And I know Barry Farber has done a lot of stuff on this, and particularly what the supervisee doesn't tell the supervisor, which can be important. And
I'm not saying, I have had supervisors that were such idiots that I didn't tell them, because when I tried, they were stubborn and teaching old tricks that made no sense. So I think that there may be times when a therapist has to have, there's always some divided loyalty between patient and supervisor that every therapist will feel. But there may be times when a therapist has to do what they think is right. If a stubborn supervisor thinks that, it has to be this way, and you're sure that it can't be that way with this patient, there are times when you may have to not make everything open. But that should be the exception.
yes,
Most supervisory relationships, there should be enough of an alliance that whenever there's a difference of opinion, that becomes the useful material for discussion.
and that makes supervision very, very challenging, because they say you have to keep your eye on the ball. When you supervise, you have to keep your eye on two of the balls. One, the learning experience of the supervisee, and the other, the welfare of the patient. And if the supervisee is messing up and can do harm to the patient, or is not even helping the patient, and as a result of that is prolonging the problem, and my rule of thumb is to overrule the supervisee and say, here's what has to be done. And in some instances, it even has resulted, if it was a chronic type problem, in the termination of the supervisee, the student, because they were doing harm. Somebody needed something, and I think dates back a while. This was a sexual minority patient that needed to deal with certain issues, and the supervisee said, "I can't talk. It's just too uncomfortable for me to talk about it. I can't do it." And there were other things that were too uncomfortable. So this person, then there was the danger, and it's a tough call, but it's a judgment call. And to let somebody, there are a lot of lousy therapists out there, and if the supervisor feels, and this is tricky, that this person is going to go out and do harm, then I think there needs to be very careful thought about whether this supervisee should actually go out and do therapy. Which
And
is
I think
hard. Yeah.
I think there are a lot of great supervisors out there, a lot of good supervisors out there, and some lousy supervisors out there. And I think that the more supervision any trainee can get with really good to great supervisors, much richer their career will be and their life, because you don't just change in a positive way in therapy, you change in a positive way in supervision. And I think the more you can get different types of supervisors, different techniques that they teach, different personality types, the more you get the range of what's available in your supervision. You don't learn how to do therapy in classes. You don't learn how to do therapy doing a dissertation. Where you really learn to do therapy is by doing it with patients and also being supervised. And the more supervision and the more varied the supervision and the more quality the supervision, the better a therapist will be.
Well, we're coming to the end of our podcast, but I have this uneasy feeling that we have raised more questions than have provided answers. And in some way, that may be the bad news, but it could also be the good news. That maybe people listening to this podcast could go on and try to come up with better answers than we have.
Well, also, it an inevitable result of it depends. So because everything is it depends, if we had clear answers to any of the questions, we would be misleading our listeners. That really the best answer we can give, it depends, and to be flexible.
I would also venture to guess that we could, on certain kinds of issues, we can get some consensus on interdependence. And that would be nice, because that would be a great trick to teach our supervisees.
Well, it's fun to do every week with you, Marvin.
Okay. We'll talk next week. Stay safe. Bye-bye.